Well, welcome everybody to the Silicon Valley Health Institute. We are a nonprofit organization. We have leading experts in the world on various health issues. Now, you women out there might not think that prostate cancer is something that concerns you, but as I understand it, there's many commonalities between the risk for breast cancer and prostate cancer. Includes estrogen, perhaps testosterone going through the aromatase pathway to get more estrogen, insulin resistance, and all these interconnected things. So I think, ladies, and Steve will certainly tie these together so that what we can learn about from prostate cancer, see what might apply to breast cancer. But today we have a fascinating gentleman. His name is Peter Starr. He's got a fascinating history. I mean, he sent me a picture of himself with Mick Jagger when they both looked like they're almost in swaddling clothes. It was very cute. Anyway, as a history of television, radio, rock and roll was racing, the history of television, etc., motorcycles marched to the 60s and 70s to the present day. He's been in lockstep and responsible for some of the important developments in all these areas. From racing motorcycles and working for the legendary Trump Marquet as a host.
Not Trump, Triumph.
I'm sorry. I've got a phobia and I tend to project or something. Legendary Triumph, Marquet as a host and producer of innovative radio programs, including the likes of Paul McCartney, Peter Townsend, Eric Clapton, and Jimmy Page, to mention a few founders of the modern rock and roll. He has a recent award-winning film and television commercials and groundbreaking specialized camera equipment. He's been involved and continues to be at the forefront of the most exciting era in film, television, and motorsports. His most famous feature film, Take It to the Limit, has received gold and silver awards at the Chicago, Houston International Film Festivals. In addition, his films have won an additional 12 international awards and his radio program a gold and silver award at the New York International Radio Programming Awards. He's produced and directed over 40 television specials on motorcycles and motorsports. Among his breaking first are the first camera mounted on a motorcycle during an AMA national race, Laguna Seca, in 1980. I don't think that's the American Medical Association, folks. The first live broadcast, I just don't think so. The first live
Oops, we lost you.
Yeah, yes, I'm here, but I can't hear you. You're gone.
Well, I think Susan's connection just went down, so let's let her come in. Why don't you go ahead and start off and make some introductory remarks?
Michael show. He brought Starr's beer to the dirt track and created the Starr Miles in 1984-85, broadcast on the Nashville TV network and USA network. And his documentary, which is what we're going to be highlighting today, Surviving Prostate Cancer Without Surgery, Drugs, or Radiation. But feel free to ask him about any of these things because he's such a fascinating guy. So welcome.
Thank you. Let me start out by saying one thing. You mentioned in the beginning about PSA not being a woman's thing. Do you realize that you can actually measure PSA in a woman? They produced what is now, what used to be considered prostate-specific antigen, but actually no longer. It's no longer prostate-specific. It's the same protein, but women make it also. I thought you might find that interesting.
So what kind of diagnostic significance does it have in women?
I'm not having a good time with the audio here, so let's see what else I can do that's different. I'll try that, see if that makes any sense. I'm sorry, I missed that question.
The question was, what diagnostic significance does the PSA have in women?
Nothing that I know of personally. It's just a statistical fact that in very, very small amounts, it is found in women. And but other than that, it's not something I've pursued to find out why or how. But at a scenario, at a conference I was at, we were discussing the significance of PSA in men. And one of the doctors stood up and said, oh, yes, you can now measure it in women. I was in there for another reason, didn't pursue it with him, but it has been measured and apparently continues to be measured in women in very small amounts. It's also not prostate specific, and we've known that for a long time. As an example, if I was to thump you in your breast as a man, your PSA would spike. It's actually manufactured in the breast as well. It's not just prostate specific anymore. And it's been a long time since Thomas Hamblin actually discovered the protein that he called prostate-specific antigen. And research has gone on way beyond that. And Hamblin himself said that he wishes now that it hadn't been made such a big fuss of when it was, because Thomas Stamey, who was a doctor up there in Stanford, in your neck of the woods, I think, in the very beginning made the PSA test almost like the standard for detecting prostate cancer, when in actual fact, it has very little relevance as to whether you have cancer or not. It's not an indicator of, it's an indicator of inflammation, not an indicator of cancer. Necessarily. Wow. The inflammation may be caused by cancer, but you can also have a very high PSA count and no cancer. And I've come across that frequently. On the other hand, you can have a very low PSA and have a high degree of cancer, which was my case. My PSA was 1.2, and yet I had a Gleason score 7 of cancer in about 80% of the prostate. So you've got to be very careful when we talk about PSA, because it isn't what it was when Thomas Stamey started to talk about it 30 years ago now.
So would you have a kind of a spectrum of indicators for men to pay attention to regarding PSA cancer risks?
Well, if your PSA is high, you should certainly have it looked at, because there's still a possibility that it is cancer. But to go ahead and do a biopsy is, in my opinion, foolish, because doing a biopsy actually releases a whole bunch of other issues that, quite honestly, you don't want to deal with unless you have cancer. What we recommend is either you do an MRI with and without contrast, or a thing called a 3D color Doppler ultrasound, which is a way to look at the prostate through ultrasound, but it's a Doppler in it, and you can measure things like blood flow. You can see in live time whether there's lesions in the prostate, and you can measure the blood flow to the lesions, if there is such a thing, to determine whether or not it's cancer or just benign growth. And then you have a choice. The choice being then, if you think you have cancer, then if you're going to do conventional treatment, then you're going to have to do a biopsy, because conventional urologists will not treat you without having a biopsy. But if you decide to go the natural way, then you're ahead of the game, because you've not done a biopsy and you've not put needles in there and upset the general equilibrium that's in the prostate.
Is that Doppler ultrasound a difficult test to find, to get access to it?
No, it's not difficult to find. It's difficult to find someone that can interpret it as far as the prostate. Every hospital has one. Every hospital uses it. Very, very few actually use it with regards to the prostate. We have a couple of doctors down here in LA. There's one in Phoenix that I know of personally. There's one in Seattle, and that's on the West Coast. There are several on the East Coast. You've just got to figure out who's got one, and it is covered by Medicare if you're a Medicare patient, and it's covered by most insurance anyway. But quite honestly, and I've tried to say this to Siemens and to Hitachi, who make the equipment, they need to do an educational tour of the country to these hospitals and say, hey, here's another way to use the equipment you already own. But so far, I've had no interest from either Siemens or Hitachi in taking this on and doing something about it.
What are your concerns about, your general concerns about biopsies?
The main thing is that over the years, I've learned that biopsies generally upset a lot of things. With the prostate specifically, it's a painful thing. It's not done under general anesthetic. It's done on a very local anesthetic, which actually doesn't work all the time. And sometimes when it does seem to be working, it doesn't work the way that we think it's going to work. You lose a tremendous amount of blood over a couple of days, because after the prostate has been invaded like that, you're peeing blood. And if you're having a sexual relationship, you can ejaculate blood. And that goes on for anywhere up to 3 weeks. 2 to 3 weeks is, sometimes it's 2 or 3 days, but I've known 2 to 3 weeks to be the case. And the thing is, when you put a needle in it, it's a 1.5 millimeter needle. It goes in about a ½ inch. The issue is you're not necessarily biopsying the part of the prostate that may have cancer. Even though it's guided by a regular ultrasound picture, you can miss cancer frequently. So you can get negatives and you've actually got cancer. You can get cancer, and in fact, it can be a very small amount of cancer because they will take between 12 and 18 samples out of the prostate. Each sample is a ½ inch by 1.5 millimeters, which is a significant amount of tissue that they pull out of there. And that's what causes the bleeding, of course. And then if there is cancer and they do penetrate the cancer and they pull the needle out and you're doing so much bleeding, the chances of the cancer spreading is not to be taken lightly.
Is thermography useful?
Yes. I talk about thermography in my new book. It was not looked at very kindly when I did my documentary so much, although we did mention it there. But in my new book, I talk about it in great detail. It's not to be taken as a positive diagnosis of cancer. It's an indication that there is a problem there that could be cancer, and then you have to go decide what to do. And I would suggest then a 3D color Doppler if you've done thermography first. But thermography certainly has a place in the diagnostic process. If you have symptoms, for instance, frequent urination, getting up a lot at night, pain in the groin, lower back pain, things like that, and you decide to do a thermography, you can tell if there is significant inflammation in the prostate area, yes.
Charles?
Yes, regarding the ultrasound, years ago, I had Dr. Duke Bond. I think it's Ventura.
Yes, I know
and,
Duke.
Yeah, I actually had 3 scans by him. And they all showed that the amount of cancer was very small. And for that reason, even though I was diagnosed in 2008, I have not had any treatment.
Well, that's pretty good. And you're doing well?
Yes, doing well, but I am having difficulties now, I think, with BPH, and I don't know what I can do about that.
How old are you?
Let me see, how old am I? 78.
Yeah, I'm 78 too. We're the same age.
Yeah.
The BPH inevitably will get us at a certain point. I have issues with it today also. And there's a number of things about BPH that there isn't a great deal you can do about it with supplements that I've found. There's a lot of claims made, but very little, other than anecdotal stories, very little actual solid scientific evidence about some of these supplements that are being put out there. There is a couple of minor surgical things you can do without doing the Roto-Rooter. And it depends if you're having difficulty urinating or not. If you're not, leave it alone. If you are, then there's a couple of things you can do. One is called iTind, which is quite new, and the other is another place where they actually go. It's called Resume, and they go in and clean out the tissue around the urethra with steam. It actually kills off the cells around the outside of the urethra, and so it doesn't collapse on you. Those are the two things that I would look at if you have difficulty urinating before you look at TURP. TURP is where they go in with the Roto-Rooter, and that's, in my opinion, that's the last resort, not the first resort.
Right. Well, I'm not having any main difficulty, but I notice the strength of the stream is much less than when I was a younger man.
I would, if you're really concerned about it, I would go and have a cystoscopy done, and that's where they put a camera up the urethra as high as right into the bladder, and they'll take a look at what's going on in there and perhaps recommend either one of the two things that I suggested, or nothing at all. Or they may, there are drugs that you can use that I think could help. And it depends also, I think, on the state of your hormone levels. It's possible that Arimidex will help. It's possible that Proscar will help. I'm not a doctor, so I'm not going to recommend either one of them, but it's certainly something you might want to bring up with your urologist when you discuss that.
Yeah, the dominant effect of estrogen in older men becomes a major factor on all kinds of different systems.
Yes.
And so the direct inhibition of aromatase is one way to minimize the estrogen footprint, like with a sledgehammer.
Yeah. And every man is different. You know, it's not just the estrogen, it's also, you know, the amount of free testosterone you've got. You can have a very high testosterone, but very little of it is free. And so it leaves a lot of testosterone that's attached to proteins that aren't doing the job that they're supposed to do in the first place. So it really, I think, is a question of looking at the overall hormonal system, where you're at, and before you make any decisions that way, not just look at the estrogen level.
Right. Could you tell me again what the procedure was where you talked about releasing stream to open up the urethra some?
Well, there's two new, the newest technology is called ITIND, ITIND. You can Google it. It's information is readily available. And they actually put in a device into the urethra, into the prostatic urethra, to open it up. And it stays in there for a week, and then they remove it. And it's supposed to last for at least 3 years. They're saying longer for most people, but they're saying at least 3 years. That's an interesting thing. And the other one is called Resume, REZUME. And it's a process where they go into the urethra with a device and puncture holes through the prostatic urethra, pump in steam into the surrounding tissue, and kills off that surrounding tissue to allow the urethra to expand so you can urinate more freely.
Sounds good. Thanks for the advice.
Yeah, and then I said the last thing is, if you have to, is of course TERP. I know doctors today, that's the first thing they recommend. And I said, if you had it done, they say no. I said, you should go look at it before you recommend that first, you know. But,
I have one other question, if it's okay.
Sure.
I have my regular doctor is a fairly young person, and apparently is not well trained on prostate cancer. Probably hasn't dealt with it, and she's expressed concern because my PSA is slowly rising, and the last count was 9.1, and I don't think it's anything to be concerned about. From what I've read and learned from others, if you see a PSA shooting up, that's when you're worried. But
Well,
I don't think
and also the shooting up can be that can be a concern, but it's not the only thing that can make, you know, cancer isn't the only thing that can make it shoot up. The key is the word inflammation, and the cancer may be caused by, the inflammation may be caused by cancer, but it may be caused by other things. And by doing a 3D color Doppler, you can look at things like calcification of the prostate, and that can cause the PSA to shoot up. And you can see that on a 3D color Doppler. And there are ways to detoxify the prostate of this calcification. There's a great book done years ago called The Calcium Bomb by a couple of Swedish doctors. And there was a product at the time called Detoxamin that pulled out the calcium very well. Unfortunately, they're not on the market anymore. The company went bankrupt. And I think somebody else has picked up the actual formula, but I don't know where or how at the moment. I'm trying to find out where it's being remanufactured. But if you look up Detoxamin, and maybe you'll get to it before I do. But that certainly helps. Back in 2006, I think it was, I was in a clinical trial for Detoxamin, and I had calcium deposits in the prostate, and it successfully removed them. And they can be a source of great irritation within the prostate, which can cause the PSA to rise.
Thank you very much for the information.
Oh, you're very welcome. Good luck with that thing. And
above
all, don't panic. You know, if the doctor is putting panic into you, find another doctor.
Oh, right.
By the way, this is green tea, in case you were wondering. It's not vodka, it's green tea.
I drink green tea every morning. I also take pomegranate juice every morning.
All of that's good. You know, vitamin D is essential. I do vitamin C, B12, and zinc. You know, the other thing also, you should take a look at what your zinc content is and get some analysis of what's going on with zinc. And because there's other minerals that are important as well, boron, for instance, that isn't generally recommended by doctors, but I would take a look at the amount of minerals that your intake, amount of minerals you've got in your system. The zinc that I use is actually a liquid zinc. It's called a nano zinc. It's quite expensive. It's like $40 for a bottle. It'll last you about a month, but it's absorbed very quickly. not like the zinc capsules that you get from any one of the supplement companies. It's quite new. I was in on the first batch that it was developed here in Los Angeles at USC Hospital in Hospital in Los Angeles. And it's worked very well with me. I like it, actually. It's cut down on the amount of zinc I take every day. It's absorbed much better. But take a look at what your mineral content is, because I'm thinking now of putting together a mineral supplement that is directed at men with prostate issues. Because generally also the levels of the supplements, the minerals in supplements they give you are not significant enough for people that already have a problem. It's not therapeutic. They're more at a preventative level than they are to actually have any success with people that already have significant problems.
You
Okay.
made a comment earlier about Siemens and Hitachi not being interested. Can you elaborate on that?
Yeah, I have not managed to get any of them to return phone calls. And I've placed several phone calls to several departments trying to find anybody that'll talk to me about their 3D Doppler equipment. And I've yet to have anybody return a phone call. And I'll be quite honest, I gave up on it. I said, this obviously isn't time for me to deal with this. And I let it go and went on to other things. But at some point I'll come across somebody and we'll have a chat and we'll talk about that. But until I find that right person, there's not much to do other than go to doctors that already know that exist. There's a doctor in Los Angeles called Mark Schultz. He's in Marina Del Rey, who I highly recommend. I use him for, I'll go in once a year now to have a checkup, just to see if anything's changed, because cancer can come back. You may get rid of it, but it can come back. It's all a matter of changing your lifestyle, the way you think, the way you eat, the way you operate. Because if you slide down, there's a good chance the cancer will come back. So I go in once a year and get a checkup. If you have any contacts at Hitachi or Siemens, I'll be happy to talk to them.
There's a question here, if people have the same PSA and different Gleason scores, why would that be?
Because the two are not connected. The Gleason score is a pathological view of cells, and the pathologist makes a decision as to the state of the cells, and that gives him his Gleason score. You can have a very low Gleason score, very low PSA, as I did, 1.2, and a very high Gleason score, which I had a 7. And you can have vice versa. You can have a high PSA, but not caused by cancer. And if you have a biopsy, Gleason, you might find a little cancer, and the Gleason score can be so low, like a 2 or 3 or a 4. So the two are not connected necessarily.
Have you made dietary changes in your own program?
Significant. No fast food. That was the first thing I stopped doing. I went vegetarian and vegan for a while, but over a period of time, and it's been now 16 years since I was diagnosed originally, and I've come back to eating different kinds of protein. I eat fish. I'll occasionally eat chicken. I'm not big on meat. I don't eat meat at all, red meat. I haven't eaten red meat in 16 years. But I will eat chicken, particularly if it's in like Chinese food or stuff. I don't make a habit of it. I do eat fish. I eat lots of fish, but I tend to go for the fish that is the least polluted, like salmon from Alaska, sardines, things like that. But I try to stick to as close to a vegetarian diet as I can. I don't drink huge amounts of alcohol, which I used to do. Before when I was working, I was a stunt guy in the movies for 9 years, and we drank a lot during those times. And I'm sure that is one of the contributing factors. But I enjoy a glass of wine every now and again, but I just don't drink like I used to. I drink a lot of tea, and I just try to eat fresh food, fresh vegetables, fresh fruit. The closer to nature you can get, my belief is the better you are.
Can you tell us when you got the diagnosis, what was the path you went through and trying to deal with the prostate diagnosis?
Well, the very first thing was absolute sheer panic because, and a lot of that was instilled into me by the urologist. And this is something I try to talk about a lot, is that the doctor called me up after the biopsy, and I'm not exaggerating when I say the length of this conversation on the phone was about 8 seconds. He said, "Yep, you've got cancer. I want you to read this book by Patrick Walsh and come in and see me," and hung up. And I absolutely freaked out and went into about a 48-hour, I'm going to die tomorrow attitude. And because nobody had explained anything to me about the possibility, it was a most unkind way for a doctor to talk to a patient, in my opinion. And it took me, I went away and I spent some time with some friends because I was single at the time and had nobody really to share with me, with anybody what I was going through. So I went away and spent 4 days with friends. And at the end of that 4 days, I just came to the conclusion that I can deal with this, whatever it is. And I came back to LA and started to read books. I couldn't find the Patrick Walsh book at the time. I found a lot of other books and I read them. I did finally read the Patrick Walsh book, and I wouldn't recommend it to anybody because his first line of attack is surgery, and surgery is the gold standard as far as he's concerned. And when I talked to some of his patients, I found out, well, he's not the doctor that is written about in the book. I happen to know a couple of doctors that almost died on the table in his surgery. Sorry, a couple of patients rather that almost died on the table that he was doing the surgery on. And that drove me away, quite honestly, more than it brought me into conventional medicine. The book that impressed me the most at the time, and we're going back now 16 years, was a book by Larry Clapp called Prostate Health in 90 Days. And I read that cover to cover and I said to myself, this makes one heck of a more sense than what the other people were talking about. And that's the path I chose at the time. And Larry Clapp was alive then. He died about 3 years later after I met him. He had a heart attack, funnily enough. And well, not funny, but I mean, the word got around and said, oh, he died of prostate cancer. No, he didn't. He died of a heart attack. And he died of a heart attack while in, should we say, enjoying one of the male-female activities of life. And I don't know quite how else to put that, but I don't know how old your audience is generally, but
be careful.
Yes, but that's how he died. I knew Larry very, very well. We'd become friends. He was the one that encouraged me to make the documentary. And originally he was supposed to host the documentary, but he died. And so I ended up hosting the documentary. And prior to that, I'd been a documentary filmmaker for, close to 30 years. So I was quite comfortable being behind the camera and behind the editing machine. But all of a sudden I was in front of the camera and pretty much stayed there when it comes to projects like this ever since. But his book has a lot of information on it. We enlarged on that in the documentary, and I've brought it all up to date with the new book, which is brand new. It's right up to date with the latest information, except for ITIND. ITIND had not been approved when we sent the book for printing. That's the newest thing that we couldn't talk about because it hadn't been approved. Now it is.
Did you end up firing your doctor? your 8-second message doctor?
Well, firing isn't exactly the word. I just ignored him. But I found out something else that's really interesting about doctors. He sent me for a second opinion, and which I was happy to do. And the doctor he sent me for second opinion was at Cedars-Sinai. I won't mention any names, but when he found out who my primary urologist was, he actually gave me exactly the same recommendation as the first doctor. It wasn't a second opinion. In fact, he wanted to rush me into the booking room to book surgery. That was and I found out later, I didn't know this at the time, that they all belong to the same club. They all play golf together. And the chances of getting an honest to God second opinion, I don't think was a good chance of that. They didn't once send me to a radiation, to explore radiation. And proton beam therapy at that time was not approved. It wasn't happening. So that wasn't even on the table. And what certainly wasn't on the table was what Larry Clapp talked about. And I think doctors, to be quite honest, if you don't do what the urologist tells you to do, he doesn't get a paycheck. That's the bottom line of the whole thing. And although the urologists that I've met recently, I met a couple, I had a long chat with some out at Loma Linda Hospital, which is fairly close to where I live. And they're much more open today to exploring the non-invasive side of dealing with prostate cancer than doing the invasive side. They're not tied to immediately saying, you've got to have surgery. You know, and I found that quite refreshing, to be quite honest, compared to 16 years ago. And I'll tell you something else that's interesting on that same thing. Michael Milken has a prostate cancer foundation based in Santa Monica. And other than initially when Michael Milken took an androgen deprivation drug, I'm not sure which one it was. I don't know if it was Lupron or not, but he took that immediately for a while, but never had any conventional treatment beyond that. Changed his diet, changed his lifestyle, changed everything else. And yet the programs that they promote the most are still surgery, drugs, and radiation. And I find that disconcerting, to say the least. Why doesn't people like Michael Milken, and I don't know the man, so I'm only telling you what I've learned through, I've met people from his foundation. Why don't they come out and have a department in their foundation dealing with this? I'd be happy to give them my information. No problem. You know, it's just that it seems you're either one side of the fence or you're the other, when in fact, we really should be both on the same side of the fence.
Or on both sides of the fence, straddling it.
Exactly, yes.
Yeah, I think there's a lot of institutional fear of illegitimacy or perceived illegitimacy.
Mm-hmm.
Bob,